everybody has seen the PowerPoint. So yes, as Crystal said, my name is Nick Dunlap. I am a licensed professional clinical counselor, and I am also one of the consultant and trainers for the Coordinated Specialty Care for First Episode Psychosis program here at the Best Center. And my didactic today is going to revolve around the treating of affective psychosis in Coordinated Specialty Care for First Episode Psychosis programs. And as we look at the objectives here, hopefully this will, oh, there we go, perfect. I want to preface a couple of things. First and foremost, now I'm well aware that some programs have been including affective psychosis in eligibility criteria for a while. So this might be a review for some of the providers that are in that program. However, some of the programs, some CSC for FEP programs have just recently started to expand diagnostic criteria to include affective psychosis. So looking at, for example, bipolar disorder with psychotic features or major depression with psychotic features. And so hopefully this will help some of the providers in that program to understand a little bit more about how to incorporate those specific diagnoses in their programs. Also, in the interest of time, as part of the didactic for our ECHO today, I'm not going to go into a lot of the diagnostic criteria for affective psychosis. That could take some time. But it does bring up a point that we want to make sure, as with any diagnostic label that we might be using as part of our program, we want to ensure that we're comfortable and have the ability to explain to participants and their loved ones diagnostic information in their terms and in the way that they can understand that. And I'm going to refer back to that over the course of the presentation today, because sometimes we don't have to put a label on it, right? So if someone's coming in and they're working with us, we have to have a diagnosis for various purposes in community mental health. But sometimes that's not as important as a working relationship that we might have with a participant. Maybe they're coming in because they really want to work on their independence. Maybe they want to come in because they want to get back to work or get back to school. So they're not overly concerned with their diagnosis. They just have other goals that they might want to work on. And so we'll talk about that briefly again over the course of the didactic here. So much of the information that I'm going to talk about is included in this issue brief by Drs. Bello and Dixon. This will be, the whole issue brief will be available along with the PowerPoint that I'll be reviewing today. It will be available for you to review. Part of this issue brief deals specifically with treating affective psychosis, but also, and just as relevant, is it does include information on treating substance use disorders as well. So again, could serve two purposes, not necessarily for this didactic, but maybe for other participants that you might be working with in your CSC for FEP program related specifically to substance use disorders. So I'm going to start off with and talk a little bit about what are some of the benefits and advantages of early intervention in affective psychosis. So kind of looking at a big picture of any CSC for FEP program, one of the big goals is by shortening the duration of untreated psychosis, or DUP, of participants. And so when we are able to expand diagnostic criteria to enroll more individuals, by helping those individuals and helping them get enrolled in treatment sooner, it can help to reduce that duration of untreated psychosis. So along with reducing the DUP are improved outcomes. So in any number of areas, and there's a lot of research and evidence to support that. And so as we are able to meet with more people, we can improve outcomes, not only for participants, but also hopefully for their families and their loved ones as well. It can help reduce the challenges of the lack of diagnostic clarity. So for example, maybe if a CSC for FEP program did not enroll or has not enrolled individuals with an affective psychosis diagnosis. Sometimes there is so maybe they were just enrolling individuals with schizophrenia spectrum diagnoses. So an individual might be coming in and there's a lack of clarity. Okay, is this schizoaffective disorder or is it bipolar disorder? And there might be some confusion. And so for teams that are able to start to enroll individuals with affective psychosis, that's irrelevant, right? We can get them enrolled. We don't have to kind of go back and forth and take a lot of time to decide if they are diagnostically appropriate. And then also enhancing the stability or sustainability of our program and stability. We'll use both of those. So hopefully by enrolling more individuals, we're able to show that the CSC for FEP programs, they work and they can help participants and their families in any number of ways. So it's always a good way to show that we are able to reach more people and help more people. So just a little bit in terms of looking at the prevalence in the course of affective psychosis. So when we look at outcomes, obviously, as I mentioned, reducing the duration of untreated psychosis is very important. And so it's also important to note that there are some advantages when you're looking at early intervention of affective psychosis. So some studies demonstrated that early intervention can help prevent and reduce suicidal behavior or suicidal ideation. Medications and CBT interventions, they tend to be more effective in early stages. So the sooner that we can help to provide those types of interventions, it can prove and help to improve long-term outcomes. And then decreased likelihood of financial, employment, relationship, self-esteem problems. And one of the things that I'll touch on a little bit later when I talk about some next steps is looking at the therapeutic alliance. So common in CSC for FEP programming that when we have a healthy relationship with participants that we work with, it can help decrease treatment dropout, better functional outcomes. And so I'm going to touch on that, especially given our current state of community mental health, and looking also at providers within CSC for FEP programming and how we can try to help sustain that therapeutic alliance if there is change in providers. Someone maybe is leaving and they're getting to know a new case manager. How can we try to keep that therapeutic alliance going and healthy? So I'm going to touch a little bit again on adapting some treatment services. And so first and foremost, when we're looking at prescribing practices, again, in the interest of time, there are some differences. There are changes in the course of medication regimen when you're talking about affective psychosis. We could do a whole didactic on just that alone. But as highlighted in the issue brief, it does bring about some important points. So things such as medications such as mood stabilizers, for example, lithium as an example, they do require follow-up. They do require regular blood work. And so when you're working with participants, making sure to talk with them about that and the importance of completing that blood work to ensure any issues or concerns can be addressed as a result of that medication. The other thing that the issue brief brought up that I thought was really important is that when we're talking about depressive disorder with psychotic features, there's evidence to support that an antidepressant medication along with an antipsychotic medication is seen as most effective. So that would be as opposed to just an antidepressant medication or just an antipsychotic medication. The combination of the two medications together can prove to be most effective. As I touched on engagement, and one of the things that I think most anyone who has worked in community mental health recognizes that participants' desire to engage in treatment or willingness to engage in treatment or even wanting to show up for appointments, it will wax and wane it will come and go, depending on maybe what is going on in their life in any given moment. And I think one of the things where this can really come up is individuals maybe that are dealing with symptoms of bipolar disorder. So they may reach out for help when they're in a depressive phase of their bipolar disorder. They may be wanting help because they're not feeling really good about things. But then maybe they fluctuate into a mania phase and they're feeling good. They're not really like, oh, I'm okay. I don't need to go to my appointments anymore. Oh, I don't need to take my medication anymore. And so we need to recognize that the kind of the symptom related barriers that a participant might be experiencing as they're going through their treatment. Also looking at psychosocial interventions. And so talking a little bit about interventions that address negative thoughts, dysfunctional beliefs. So these might include statements such as, I'll never be able to work again, I'll never become independent, or even statements such as, I'm worthless. So being able to work with participants on those beliefs, it can help to instill some confidence for them and also help to reduce maybe the self-stigmatizing nature of some of those beliefs that they might be having. The other thing is very important when we're addressing those beliefs is we have to be willing and ready to modify those techniques to ensure cultural appropriateness, right? So let's say that a person of color maybe is reporting to their provider, I'm scared of the police. Now, where it's important that we want to ensure cultural appropriateness is if, let's say that belief isn't consistent with me as the provider. So maybe I don't share that belief. If I start to encourage the participant to challenge that belief without taking into account cultural aspects of that belief, then it can be seen as very disrespectful. It can be seen as dismissive, because let's say that this individual has had lots of experiences of law enforcement following them or tracking them. Or maybe there was just a recent news article or a story on the news of a person of color who was killed during an interaction with a law enforcement officer. So that belief may be part of that individual's kind of core belief system, that they are scared of the police based on their experiences. So we want to be very mindful of how to modify our approaches from a cultural perspective when working with participants in these areas. So what's next? What can we do in working with participants that have been diagnosed with an affective psychosis disorder? So first and foremost is looking at outreach, right? So as we have been working in CSC for FEP programs for a while, we want to make sure that those partner agencies that we work with also internally, so talking about intake departments, assessment departments, reminding them and making them aware of the expansion with regard to diagnosis. So letting them know, if you're working with an individual that has been diagnosed with bipolar disorder with psychotic features, they can come our way into the CSC for FEP program, and making sure that they are equipped to have that information and know what to do. The other thing is, as I touched on when I first started, in the current nature of community mental health and kind of dealing with the constant turnover that is occurring. And while it is frustrating for agencies, CSC for FEP teams, we also want to recognize it's equally, if not more frustrating for participants that we work with when they're getting to know a provider, a case manager, a therapist. They're getting to know them, they're building that rapport, they're building that trust, and then they leave. And then they have to build that relationship with a new provider. So we have to take into account when we're looking at this from a capacity perspective. So developing plans within the programs on how can we introduce new providers to participants? How can we try to, I don't want to say ensure because that's not going to necessarily always be possible, but how can we try to address this concern on behalf of participants when they are having to work with their third case manager in a year, and having to repeat their story and tell their story over and over? Very frustrating, right? And so thinking about that from a program perspective, and even bigger, thinking about that from an agency perspective as well. I touched on some of these with regard to strategies. So maintaining flexibility, this is especially true with families. So if I'm working with a participant and the family member comes in and is just feeling really frustrated because their loved one is, one day they're struggling to getting out of bed and getting out of the room. And then the next day they are nonstop full of energy and action and wanting to do things. And then the next day they're back in their bed and not wanting to get out of bed. That's incredibly frustrating for families and loved ones to be able to help and know how to best approach working with their loved ones. So the other thing that I touched on as well is paying attention to the nature of the illness that the individual is dealing with and how treatment approaches can be adapted. So as an example, so if someone maybe is experiencing mania symptoms and they're feeling good and they're ready to take on the world and they want to make a huge lifestyle change or a life decision, they want to move to another state. It looks like it'd be fun to live in California. I'm going to move from Ohio to California. That would be a good time. We want to make sure that when we're working with participants to not just be dismissive of that desire to make that move, but helping them to work through and talk through what's prompting that decision at that given moment. Because that could have, it could be playing an impact, could be playing a role on the participant's decision to be doing that at that given time. So I am going to open it up. If anybody has any questions, I'm certainly open to answering any of those. I'm going to stop my share and I will turn it back over to Crystal. Where's my share button?